Welcome, everyone. Thanks so much for joining us. We'll just give it a minute or so for the rest of our attendees to join. Welcome, everyone. Thanks so much for joining. We're just going to give it another minute here for those just joining us. Just give it another second here. Just to note that everyone joining as an attendee, your video is turned off and everyone is muted. So you can use the chat function if there's any questions. All right, in the interest of time, we'll get started. So good afternoon, everyone, and thank you so much for joining us today for our webinar titled Perspectives on a Public Health Approach to Substance Use, Findings from a National Survey and Tools for Future Work, presented by the Canadian Public Health Association as part of our Normalizing Conversations project. My name is Kelsey McIntosh. I use she and her pronouns. I'm a senior project officer with CPHA and will be the moderator for today's webinar. Before we begin, we want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe. They've been the guardians of this land for millennia, and we're grateful for the example that their stewardship provides. We recognize that working towards reconciliation goes far beyond this acknowledgement, and while CPHA is making strides to embed truth and reconciliation in our work, we encourage you to learn more about the land you reside on and take opportunities to learn from Indigenous people and communities across Turtle Island. As we move into our conversation today on a public health approach to substance use, it is imperative that we acknowledge the disproportionate impact and harms of substance use stigma and criminalization on Indigenous people. This emphasizes the need for a culturally safe, decolonized, anti-racist approach to substance use, which Dr. Watson will discuss in more detail today and in an upcoming discussion paper. To provide some background, in 2020, CPHA was funded for a 4-year project titled Normalizing Conversations, Engaging Public Health, Public Safety, and Communities to Build Capacity for a Public Health Approach to Substance Use. This project has involved working with communities and people with lived and living experience across Canada, creating and updating this Canadian Substance Use Resource and Knowledge Exchange Centre. This is also known as SURE, and we'll post a link in the chat. And publishing resources that can be used by professionals across Canada to learn about and implement a public health approach. Additionally, this project has involved establishing a working definition for a public health approach to substance use that has been informed by people with lived and living experience, community organizations, and health and social service professionals. You can find more information about the project at substanceuse.ca and by signing up for the SURE monthly newsletter. A few quick housekeeping notes just before we begin. Firstly, if you have any questions for our presenters today, please type them into the Q&A box at the bottom of your screen. After all of the presentations are complete, we'll be reading out these questions to our presenters who will have an opportunity to answer them. We strongly encourage attendee participation, and we look forward to hearing your perspectives and questions. If you have any technical difficulties, you can let us know in the chat as well. Next, our webinar is being recorded today, and it will be made available on CPHA's YouTube channel and on the SURE website a few days after the end of the presentation. And finally, we would love to get your feedback. So after the webinar, please fill out our 5-minute survey. This will open automatically in your browser once you close Zoom. This feedback really helps to inform our webinars and gives us a better sense of what topics you'd like to learn about in future sessions. Now I'd like to introduce our speakers for today's webinar. First up, we have Dr. Tara Marie Watson, who earned her PhD in Criminology and Socio-Legal Studies at the University of Toronto. Her longstanding research interests include drug policy, harm reduction, and community and prison-based substance use and mental health services. She is an interdisciplinary researcher with years of experience in knowledge translation and dissemination. Dr. Watson is currently the Associate Director of the Research Program at the University of Toronto's Temarty Faculty of Medicine, Department of Family and Community Medicine. Tara Marie has played an integral role in the creation, dissemination, and analysis of CPA's national survey, which we'll hear about in more detail today. Next, we have Dr. Nancy Poole, who's the Director of the Centre of Excellence for Women's Health, a research and knowledge exchange center hosted by BC Women's Hospital and Health Centre. In this role, she leads network development, research, and knowledge exchange related to improving policy and service provision on gender and women's health. In 2021, Nancy was awarded an honorary doctorate by the Justice Institute of BC in recognition of her contributions to women's health, including trauma-informed practice and the treatment of substance use and addiction. Joining Nancy today, we have Dr. Lorraine Greaves, a medical sociologist and senior investigator at the Centre of Excellence for Women's Health in Vancouver and its founding executive director. She has worked in academia, government, education, and NGO settings in BC and Ontario. She's a clinical professor in the Faculty of Medicine at UBC and an expert in sex and gender, tobacco, cannabis, alcohol, substance use, violence, and trauma. She focuses on the development and integration of sex and gender science and sex and gender-based analysis plus in research, care, health promotion, and policy. She is chair on the Scientific Advisory Committee on Women's Health Products and previously a member of the Scientific Advisory Committee on Vaping Products. Through our partnership with the Centre of Excellence for Women's Health, Nancy and Lorraine have both worked with CPHA to publish the Public Health Approach to Substance Use Handbook that we'll hear more about in their presentation. And finally, we have Danielle Corey, who is the Outreach Coordinator at St. Leonard's Society of Canada, a national charitable organization dedicated to promoting humane and informed criminal and social justice policy and practice. She is particularly passionate about supporting the work of halfway houses, the community reintegration of people exiting prisons, and amplifying the voices of people with lived experience of justice system involvement. Danielle has an Honors Bachelor of Social Science in Criminology from the University of Ottawa. She's also a part of a volunteer group that supports individuals serving life sentences in both a maximum and a medium security institution. Danielle has been involved in CPHA's project as a member of our expert reference group, who helps to oversee and guide our project work, and will join the other panelists for the Q&A portion of today's webinar. So we want to thank each of you for joining us today. And with that, I will be passing it over to Dr. Tara Marie Watson for our first presentation.
Thank you very much for the warm introductions, Kelsey, and thanks everyone who is joining today. I'm really looking forward to this presentation and more importantly, the discussion that will follow. As you heard in the introductions, I'm Dr. Tara Marie Watson. I'm currently based at the University of Toronto. And for me, it's a real pleasure as I reflect on the last several years to present this work to a wide audience that is comprised of some of the stakeholders who participated in this national survey. When I was invited to come on as a research consultant to lead this work with the CPHA in 2020, I knew it would be an impactful survey, and it's really been a joy to work on this project. So I want to extend my thanks and acknowledgement to the CPHA team, first and foremost, particularly the Director of Programs, Greg Penny, and the rest of the team as well. And although we don't have a slide specific to any conflicts of interest, I just want to declare or state that I have none to declare. Okay, so again, this presentation will give you an overview of key findings from this survey of professionals, but you will find many more findings actually contained in the final report. You'll see the graphic on the screen. On the SURE website, a public health approach to substance use, survey of public health, public safety, health, and social service professionals. So I definitely invite folks to take a look at the report and additional resources that have been built off of this work at another time, because it was a really rich survey And I think you'll hopefully get a glimpse of that as we go through the presentation today. So again, this project that was introduced earlier in the webinar that was led by CPHA was a multi-year project aiming to enhance the knowledge and capacity across diverse professional sectors around the implementation of a public health approach to substance use. And so when you're trying to engage with professionals, practitioners, and people who are engaged in work that impacts the lives of people who use substances across a geographically dispersed place such as Canada, people working in varied fields. An online survey really does offer a lot of opportunities to reach a wide range of stakeholders for data collection. And that's why this national survey was chosen as a primary methodology. So the survey aimed to better understand, just as a quick summary again, key stakeholder beliefs, levels of knowledge, individual and organizational capacity, and access to information, training, and resources related to substance use more broadly, but also with a number of questions very specific to a public health approach to substance use, and trying to understand what stakeholders from different professional fields and occupations consider to be a public health approach to substance use. And to that point, it's important to note that while we hear the term public health approach often, and it's often been used increasingly so over time in policy and program documentation, it's been used often in the literature to describe approaches that are evidence-based or effective in terms of addressing substance use. But oftentimes, a public health approach to substance use has not been consistently defined, or even in many cases, not defined at all in said programs, policies, and academic literature. So this really has been an identified gap in our knowledge and presents itself with an important opportunity to understand what folks whose work involves or directly impacts the lives of people who use substances, what they think about a public health approach to substance use, and what does that mean? So we'll come back to an evolving, more nuanced definition later on that the CPHA is using in terms of a definition to a public health approach to substance use. But for the purposes of the survey, we used a very concise version of this evolving definition, which you'll see on your screen, and I'll just read out. A non-judgmental approach that seeks to maintain and improve the health of populations based on principles of social justice, attention to human rights and equity, evidence-informed policy and practice, and addressing the underlying determinants of health. And I'm hoping that maybe in the discussion we can really take up some of those components and we'll speak about them in relation to some of the key findings as well. This is a succinct definition, but it really does pack a lot in. And the reason we took this approach was because we wanted to work with an existing and evolving organizational definition of a public health approach to substance use. But we didn't want to make it too lengthy in order to see if there were key terms from this definition that survey respondents would react to. And we wanted to ask folks to unpack their understanding of this definition a bit. So that's some of the rationale behind why we use this definition. So in terms of methods, I already mentioned why the online survey methodology was determined to be an appropriate methodology for this kind of work, especially when you're not only working across a largely geographically dispersed area and multiple jurisdictions and multiple sectors and occupations, but when you're working within, constrained timelines as well, which is often the case when we're working on research projects, it's important that we reach as wide an audience as possible in a relatively short amount of time. And so you get a lot of opportunity to do that with online surveys that can be readily disseminated and are usually designed in a way to ensure that people can answer questions quite quickly and efficiently in a certain amount of time. So this survey was open from May to July 2021. We collected even more surveys than what you see on the screen, but we had over 1,000 1,041 surveys completed. So that was a very good sample size in the end. We were very pleased to see such great engagement with the survey. Survey questions were collaboratively developed to assess those key areas we talked about already: knowledge, beliefs, and capacity in relation to substance use, and specifically in relation to what is a public health approach to substance use. And I'll just say a little bit more about survey question development. We developed a series of closed, such as multiple choice questions, and open-ended survey format questions to really get a little bit more nuanced information from respondents around their knowledge and beliefs and capacity. And I think that's one of the real strengths of this survey in particular, is that we built in a lot of open-ended questions, giving respondents an opportunity to say a bit more and unpack their beliefs. In terms of distribution, we developed a contact list of relevant national, regional, and local organizations and stakeholders across all provinces and territories to help with survey dissemination. Information about the online survey, including a link to complete it and invitations to share the survey, were sent to our professional colleagues and networks and channels on our distribution list. So we really tried to get the survey out there far and wide to many different folks. And in terms of the primary survey audience for this, for the survey, there were a number of key audiences here that you see on the screen. Public health professionals, this could include a variety of different occupations: health promoters, public health program planners, for instance, health and social service providers. This could include peer support workers, physicians, nurses, social workers, and other health and social service providers as well. Public safety professionals. This included folks from law enforcement and corrections and court administrative personnel. And then we had another category that was even more open around other community-based professionals and practitioners who may otherwise interact with and or directly impact the lives of people who use substances. So quite an ambitious survey audience as well, and something that I think is another strength and unique feature of the survey overall, in that we tried to get a wide swath of people from different sectors and occupations, which is something that we hadn't seen in the literature before, particularly any literature that really speaks to perspectives on a public health approach to substance use. So moving along to some of our findings, just to tell you a little bit more about the respondents in terms of some demographics. This map shows you the general layout of proportions or percentages of where people were situated in terms of their work. You'll see that the largest proportions of the sample worked in Ontario at 37%, followed by Alberta at 19%, Quebec at 12%, and British Columbia at 10%. And then some varied and lower levels of participation from some other provinces. No survey respondents had selected Northwest Territories, Nunavut, or Prince Edward Island as their location of work. So that's something that's a bit notable as well, and we can mention later on. In terms of demographics in relation to age and age distribution, I think this slide neatly captures the ranges that we asked about in the survey. You see quite a good distribution across multiple age ranges here, where 27%, so the largest proportion of the sample, did identify as belonging to the 35 to 44 year age range. Similar proportions for those who responded and identified as being within the 25 to 34 year age range, or the 45 to 54 year age range. That was 23% and 22% respectively. But also we see strong representation from folks who identified as 55 years to 64 years of age, and some smaller proportions for the other age ranges represented. Okay, sector is an interesting one here. An important question we asked at the top of the survey. We wanted to understand what main sectors people were reporting from. And you may notice that there's a lot of different percentages on this graph, and it may not neatly add up to 100%. And the reason for that is that with many of the fixed choice, or sorry, more of the multi-choice questions we asked, we provided participants with all that apply as an option. So there were participants who could select more than one sector if they wished, if they felt that there were multiple sectors that could represent where their work is situated. And in practice, we see a lot of folks doing that, particularly with healthcare and public health. And unsurprisingly, we see that the largest proportions of the sample indicated healthcare at 43% or public health at 23%. As their main sector of work. We also see strong representation, 18% of participants selecting non-governmental organization, and similarly, 18% of respondents choosing social services to indicate their main sector of work. And we can mention that later as well in terms of potential limitation, but also it speaks to, the primary audiences of interest and how we distributed the survey. So we'll come back to that point later. That's why you may be seeing a lot of stronger representation from health, public health, NGOs, and social services. But nonetheless, still some good and varied representation from other sectors as well, including government, the justice system, public safety, and other sectors. In terms of occupation, we see again, a range here of different kinds of occupations that people selected from the categories that we developed for the survey. The largest proportion of respondents, 27%, indicated that they would describe their occupation as social worker, counselor, or other type of service provider. We see that there are similar levels of representation from people identifying as in the nursing occupation, such as nurse practitioner or registered nurse. And then we also see quite a lot of people who selected other, and we unpacked that a bit, and that was quite a varied range of different professions, including some people who use that space to say that they have an occupation in psychology. Law enforcement actually came up quite a bit under other as well. And then you see quite a bit of other occupations represented via this graph. Okay, and then importantly, one of the last demographic slides I think we have to show here, we wanted to try to understand the kinds of personal experiences in relation to substance use within the survey sample as well. So to do that, respondents were asked to select a statement that best describes their experiences. And it's again a question where people could select more than one option. And I think that was an appropriate use of select all that apply, because people do tend to move through or may identify with more than one of these categories. As you see from the numbers on the screen here, 69% of the sample, so a majority, said that they work directly with people who use substances and or people who are in recovery. Unsurprising, given the sectors and the occupations that were well represented in the sample. But working towards some other kinds of experiences, 61% of the sample said they have close friends or family members who use substances. Just over half, 54% of the sample, said they work on policies, programs, or practices that directly serve people who use substances. And an interesting finding that we may want to touch on later is that 45% indicated that they use or have used substances themselves. And I note that that's interesting because it's a discussion point in the full report where we take up, because that finding initially struck the research team as a bit low, particularly in relation to some other government statistics around substance use, especially when people are asked in some larger surveys about alcohol or other legally regulated drugs. Sometimes we see higher numbers than that. So that was a bit of a curious finding. All right. And now we get into some more findings. And again, I want to emphasize that, we are presenting quite a distilled overview of the survey here that we hope is of interest and really does bring together some of the more interesting findings from the survey. But again, there are some other really great findings that are quite informative in the full report. And we'll talk a little bit more about next steps at the end of this presentation in terms of maybe unpacking further findings. But we did want to focus on a few key findings for the purposes of this presentation. And what you see here is self-rated knowledge of substances. So we did ask folks about rating, their level of knowledge in relation to the different substances that you see on the screen. This includes alcohol, cannabis, nicotine, opioids, psychedelics, stimulants, and sedatives. And what you see here is that it's quite clear using this kind of heat map graph or table where there's a density of responses. And so in terms of advanced knowledge, the one substance that gets the highest rating there would be alcohol, where 63% of the sample endorsed that they felt they had advanced knowledge of alcohol. And you see, some interesting findings. We don't have time to get through all of these today, but you can take a look at this graph, read the report. You'll see that, interestingly, 28% of people in the sample said they had very little knowledge of psychedelics. So that's rather interesting, especially in view of some other findings I'll hopefully touch on as well. And you see that people are sort of hovering around half or 50% of the sample in terms of their self-rated some knowledge when it comes to nicotine, psychedelics, and also sort of getting close to that with cannabis. All right. And I think, yes, so one of the quotes here on the slide speaks to what I was mentioning a moment ago about psychedelics. We asked folks if there are particular kinds of substances for which they would like more information. And we asked folks as well to explain a bit more about their answers regarding their self-rated knowledge. And a number of specific substances came up quite a bit in their answers. I think the first quote on the screen here really captures that, and I'll read it out. Psychedelics, cannabis, and benzos, referring to benzodiazepines. There has been some research that psychedelics are as effective at depression treatment as mainstream therapeutics. Let's learn more about this topic on a societal scale. So these quotes that we're going to show you on this and some other screens are not entirely representative of everyone in the sample, but they've been selected because they do illustrate some of the key themes we talk about a bit more in the report. And again, I think this first quote nicely summarizes, and was quite typical, but nicely summarizes someone's impressions that there are some different substances for which they'd like more information. And in particular, psychedelics was one that a lot of folks asked about, in particular in relation to its therapeutic purposes and any connections with treatment of mental health or physical health conditions. The second quote is an interesting one too, because even though we saw that a lot of folks rated their knowledge very high of alcohol, this quote says, more alcohol or more education on alcohol would be great. I think a lot of people underestimate the devastating effects of alcohol just because it is used for recreation so often. And I should note that you'll see beneath each of the quotes a sector, and that represents the sector from which this particular participant, whose quote we were using comes from. So we did hear from a number of participants strong interest in learning more about alcohol, and in particular in relation to harms related to alcohol use. And so we're going to talk about harms in a moment as well, but we asked participants similarly about their ideas regarding perceived benefits and harms with substance use. So you see another heat map here, and I think that this one is quite interesting as well, because we asked people to rate how they found these same substances, how they would rate them in terms of perceived beneficial impacts towards society. And we wanted to ensure that we had a very balanced, set of questions that ask people about harms, about benefits, as well as harms. And this is something that came through very much in the survey responses as well, that people thought it's very important, especially when talking about a public health approach to substance use, that we talk about benefits as well. And so I think that this heat map is illustrative. It's a bit all over the map, no pun intended, in terms of seeing, distribution where it's harder to see, a clear pattern, I would say. And it's instructive, I think, to look at each substance by substance, right? So, nicotine's an interesting one here because it's a legally regulated substance. And you see that over half the sample are saying that there's no beneficial impact in their opinion related to nicotine. And only 1% would say there's major beneficial impact there. If we look to psychedelics, which again is a substance that many people spoke about in their answers and found of interest, you see a very different breakdown of proportions where 38% felt that psychedelics have no beneficial impact, but 24% said very little beneficial impact, 23% said some. And so it's interesting to look at each substance, I think, in turn. And that's something that we may want to unpack a bit more as we go through. In terms of, well, I might just go back a moment. Oh, there we go. In terms of benefits, oh, I'm all over the map here. Kelsey, I may ask you to take me back a moment, if you can, to the benefits. Yes, thank you so much. Just want to say a little bit more about benefits, and apologies. It's hard to see the little place where I can advance the slides on this particular slide. A little bit more about benefits. When we asked people to specify the types of beneficial impacts that they were thinking about, we had over 250 responses to that question, and we heard a variety of key benefits related to substance use. And I'm just going to mention a few of them before advancing to the next one. We heard about pain relief, management and improvement of health and mental health concerns and symptoms, supporting general mental health and well-being, coping with experiences of trauma, violence, and marginalization, supporting substance use treatment and or withdrawal management, replacement or substitute substance use, and social connections and social inclusion, as well as pleasure, fun, and recreation. And lastly, in particular, some people mention this in relation to some of the legally regulated substances like cannabis, the potential for employment and positive economic opportunities. So I think it's really interesting when we look at the report in full and talk about some of the different benefits around substance use. So just moving on to harms, I won't spend as much time here, but again, you see a heat map with a description of harms and the proportions, I think show a bit of a clearer picture in some ways when you look at this heat map. It would be interesting to hear what other people think in relation to that. But here you see a lot of the higher proportions move into the categories around perceived major harmful impact, as well as some harmful impact. And I would just point out, and not surprisingly, given the ongoing devastating opioid toxicity and overdose crisis that's been experienced, I think it's unsurprising, given that background, that opioids received a large majority, 82% of the sample, perceiving them as having major harmful impacts. That would be my interpretation of that kind of finding there. Similarly, we see stimulants and alcohol also receiving significant majority support under major harmful impacts. And it's also interesting when you look at the other end of the table that most of the substances don't receive any ratings under no harmful impact. So there are some interesting findings there as well. And I'll just say, similar to how I talked about perceived benefits, that some of the perceived harms, when we ask people to explain what they're thinking of, again, we saw many different answers, but we could group those answers by some of the following, and I'll just note these as well. Overdose and mortality due to overdose, chronic disease and various cancers, emergency room departments, mental health concerns, concerns about addiction or dependence, impaired driving, loss of work and unemployment, financial problems, family and relationship problems, stigma and discrimination, violence and trauma, especially this was contextualized by a lot of participants, especially people thought the increased likelihood of being a victim to violence, encounters with the criminal justice system and disproportionate policing, and litter and other environmental impacts. So those are some of the major harms that people spoke about in their surveys. Here on this slide, we have some quotes that nicely summarize some different views on benefits versus harms. So looking at the top one from someone from the social services sector talking about perceived benefits, they capture some of those benefits I talked about earlier. Many people I know cope with their trauma by using substances, opioids, stimulants, etc. It's for this reason that I feel it has some beneficial impact because it allows people to move through the day and continue on with life despite their mental health challenges. And then a quote that comes from someone reflecting on perceived harm, someone from a non-governmental organization. This is an interesting one here. The substances do not cause the harms. It is the context in which people have to use their substances that cause them harm or cause them to be harmful to themselves and our communities. And we unpack that a little bit, I believe, more in the report as well. The idea that it's especially around the social structural context where there's greater, contribution of harm than the actual substances themselves. So maybe I'll just say a few notes about this finding as well. We asked people a question about their beliefs regarding why people use substances. You see some very high proportions on this graph. And I think that that reflects, again, a question where we asked people to select all that apply, because we know that people may hold and do hold very different beliefs and can hold competing beliefs about why people use substances at the same time. And that's something we very much see reflected in some of the survey findings. In this particular question, with this particular question, I think it's interesting to see that overwhelmingly, for a number of sort of core beliefs around substance use, there was strong majority support, or I should say a high proportion of respondents, over 90%, all endorsing stress, response to trauma or violence for social or recreational purposes, as we talked about under benefits, for pleasure, as we also talked about under benefits, and dependence and addiction. And close to 90%, 89% of the sample selected pain. So this is a really interesting slide because it really does show how people may have multiple and different active beliefs regarding why people use substances. And in relation to that, there were just a couple quotes on this screen. Many people who provided their open-ended answers regarding their beliefs said that what I just said, essentially, that there are many different reasons why people use substances, and there are different beliefs around why people use substances. And here are just some. The top quote on this slide says, drugs are used for many coping strategies, but people often forget that drugs are also used for pleasure and fun. Someone from government. And the second quote here, I think pain and trauma is the greatest reason for substance use. Also wanting to maintain a social connection. All right, on this key finding slide, we see some breakdown of the impacts of stigma. So 67% of the respondents rated their knowledge of how stigma affects substance use as high. So, we can talk about this later on, but of course, a key goal from this survey work, the larger project that CPHA has been conducting on normalizing conversations. A key focus and goal has been around stigma and what can we maybe develop, or what kinds of resources are needed to aid in stigma reduction around substance use. So many people rated their knowledge of how stigma affects people who use substances as high. 84% agreed with the statement, I've witnessed misperceptions or misunderstandings about substance use that lead to preventable health and social harms. And 52% of the sample agreed with the statement, I believe that people should accept responsibility for the impact that their substance use has on friends and family. Maybe that's something we can take up in the discussion as well, because those two findings together are quite interesting. Again, it speaks to a lot of complexity out there, I think, where many people are saying, I've seen misunderstandings around substance use and how that can lead to health and social harms. And then, other folks saying, or some of the same folks, there would be some overlap here, agreeing with a statement that people should accept responsibility for the impact that their substance use has on others. And we had some discussions as a research team about these two particular findings and how do we interpret that, or maybe that's something we can think about in future discussions. All right. Key finding 5, and I believe there are 6. So we're getting near the end, and I have just a few more minutes for my presentation here. So I'll try to get through this one quickly here. In terms of important practices and principles, over 80% of the sample selected the following as important principles and practices from a list that we provided in the survey. So again, people could select all that apply, and a large majority of the sample said yes, Indigenous cultural safety is an important principle and practice. So is trauma and violence informed practice, reducing harms related to substance use, addressing underlying determinants of health, reducing stigma for people who use for people who use substances, improving health outcomes for people who use substances, and involving people with lived experience in policy and program decisions. And further to that, interestingly enough, again, talking about some tensions and multiple beliefs that come up, 47%, so still notable, nearly half of the sample said preventing substance use is an important principle in practice when designing policy, and 14% selected encouraging abstinence. So there are some interesting findings there as well in terms of that distribution. In terms of applying a public health approach to substance use, over half the sample, 54% of folks, indicated they had a high degree of comfort with applying this type of approach to the context of their work. So you'll see that that's expressed in this slide. 32% of the sample indicated that they had a more intermediate level of comfort with applying this type of approach in their work. Many who expressed a high level of comfort with respect to a public health approach to substance use and how they can apply it in their work simply said that this kind of approach really aligns with their existing organizational or programmatic mandates and goals. I think that might be on the next slide here. Yeah, so there's there's a diversity of quotes on this slide that capture a few different things. There was other themes that came out of looking at the open-ended questions in relation to applying a public health approach to substance use as well. For respondents who indicated a more intermediate level of comfort with applying a public health approach to substance use, concerns and observations were noted quite a bit about the lack of support for this kind of approach from their colleagues, their organization, and or agency partners. These respondents also tended to mention the challenge of having conversations about a public health approach to substance use when they are faced with organizational resistance to adopting this kind of approach. So I know we're getting short on time for my presentation, but I'll leave the quotes there for a moment for people to take a look at. There's more in the final report that really speak to some of these varied experiences and perspectives around applying a public health approach to substance use in their work. All right. And lastly, I think in terms of our key findings that I wanted to mention, this will be taken up in more fulsomely in an academic paper that we are working on. There was an interesting open-ended question in the survey around suggested changes to the survey's definition of a public health approach to substance use. So if you remember some slides back, the survey presented that succinct definition of a PHA to substance use, but it also contained a lot of different ideas. So some of the key themes that are really emerging from our qualitative analysis of that question is that many folks thought the definition needs more explicit recognition of greater inclusion of people with lived and living experience of substance use, more explicit recognition of stigma reduction as a goal, find ways to incorporate trauma-informed approaches and recognize that there are multiple pathways to substance use. That neatly ties back to some of the findings you saw earlier around, different beliefs as to why people use substances. Very much informed by people's work and personal experiences as well, which comes out in some of the survey data. And greater inclusion of community-led perspectives. And we're unpacking this further as we're working through the paper to really talk about equity and diverse community perspectives. And that's something we can talk about maybe in the discussion as well. And for some participants, not as many as some of these other themes, but there were a good number of participants who said, we should adopt a more critical look at a public health approach to substance use and its terms, and even reconsider some of the terms that were used in the survey. And in particular, the term social justice came up a number of times in those responses where folks were reacting to that term and suggested that it may not be as helpful in the definition that we're hoping to provide. Very quickly, I think I touched on this earlier, the selective sampling approach that we used was effective in getting a lot of participants in a short span of time across multiple jurisdictions across Canada. But because of the nature of our sampling methods and our distribution lists, this may have lent itself to hearing more from people who are in the health-related sectors. And it would have been great to have heard more from people in the public safety and some of the other sectors. At the time in 2021, there was a lot going on. There were priority shifts and limited survey sharing ability due to COVID-19 and organizational time constraints, which are ever present, but even more so during the pandemic. So those kind of factors may have limited survey sharing and reach for some of the other sectors that we would have liked to have garnered more participation from. And just briefly, many questions, although I see it as an important tool, many questions were designed as select all that apply, and there are some analytic challenges that can come up with those kinds of questions. CPHA has been working towards a much more comprehensive working definition of a public health approach to substance use. And it is longer in its principles and much more nuanced. And it's something that's being collaboratively developed. And I'm not going to read through all of these because I believe I'm at time. We may want to bring it back up on the screen, but you can see from this graph that there are a number of key principles that have already been mentioned that are being embedded in this working definition of a public health approach to substance use, inclusive of things like works to end stigma and discrimination, supports the underlying determinants of health and addresses health inequities, respects the autonomy and right to self-determination of people who use substances, and is collaborative and comprehensive. More information and next steps, definitely read the final report. It contains, as I said, lots of great additional information and more nuance under some of the findings. There are research snapshots available in both English and French as well. And the upcoming work include the poster presentation at CCSA's fall issue of substance conference, issues of substance conference coming up next month, I believe. The journal article I mentioned on unpacking the suggestions for defining a public health approach to substance use and framework for a public health approach to substance use. And we're going to hear more about that soon. So thank you so much. And I look forward to the rest of today's event.
Thank you so much, Tara Marie. We really appreciate your presentation. Just a reminder for everyone, if you have any questions specific to the survey report or for Tara Marie, you can post those in the Q&A, and we'll be coming back together at the end to have a Q&A discussion. So thank you again. I'm going to be passing it over to Nancy and Lorraine.
Great. Thank you very much, Kelsey. We're just going to say a few words, just over 10 minutes here, to talk about the public health approach to substance use workbook that we worked on with CPHA. And this is a complimentary resource. It's also available online. A complementary resource to what you've just heard, the sort of broad-based knowledge gathering survey, to try and bring home some of the principles and some of the approaches and lenses that are important to understanding substance use from a public health approach. So it really is to sort of reduce some of these principles to make them familiar, to share some evidence and relevant info that support them. And last but not least at all in this handbook is to provide the practical examples and additional resources.
Yeah, I think the real benefit is seeing some of these examples that come through. And, you know, we were working at the time before the survey findings were out with these core public health principles and thinking about how they could be applied and need to be applied in the substance use field. And we were very aware of the concept of social and structural justice both, and just made that assumption as we went along.
You know, the public health approach to substance use is such a broad framework. That's its benefit and value, but it's also makes it challenging to transmit the ideas behind it in a really concrete way. And also the public health approach really requires all sectors and all various subpopulations and roles within the substance use field to sort of share a perspective and work together. So it's really big. And I think that's one of the things the very short workbook is trying to address and cut through a little bit. How can we reduce this to something that various groups and sectors and agencies and policymakers and practitioners and peer-led organizations all get together and see themselves in it, and also begin to ask reflective questions after each of the principles and aspects of it to try and figure out what they are currently doing and what they could do more of. And certainly all of these things matter here.
And super important to think about how we tailor and balance these many elements, such as is listed there on person-centered, trauma and violence-informed, sex and gender-sensitive, anti-oppressive, and culturally sensitive. And it's so challenging as we do this work to think about how we, you know, tailor and balance all these things together. It's a real multitasking effort in lots of ways.
That's right. And here we have a graphic of all of, first, the principles we've just mentioned in the middle, and then all of the various lenses, for lack of a better word, or perspectives around the edge that in our process of working through various drafts of this workbook with CPHA and reference group members and reviewers, all of these various lenses became very important to articulate. And these can be applied to sort of figure out how you could expand your actions related to substance use in your particular role or sector.
And so here are those 7 things that were around the edge in the circle. And it really, you know, gives us a chance in the workbook to ask yourself and to learn about who else is already using these approaches and how and where we need more action on them. So really it is a workbook in that sense of offering ideas and resources and of how these are being enacted, and asking you to think a bit about how is it relevant to your work, for sure. So we're just going to give a couple of examples of those 7 and how they appear in the workbook. And each section in the workbook gives a brief overview of the approach and its importance. It links to resources that describe the approach in action, and it prompts, you know, that reflection or small group discussion in your agency. And this example from the linking services lens section addresses how a range of services that address the social determinants of health are effectively co-offered or offered in a co-located and partnered way to pregnant women and gender diverse individuals who use substances. And this is, you know, the Co-Creating Evidence Project was a brilliant look at community-based services that really offer this wraparound shawl version of engagement for women and support for women.
And this one, this linking services, it's probably one of the most challenging because it tries to address all the social determinants of health in one model, but it also calls upon all sectors and segments of the substance use response system to actually know each other, work together, link to each other, refer to each other, perhaps share the same public health approach. So this is really a big one, linking services.
The next one is is mentioned everywhere in trauma and violence informed responses. And this is just an example from that section that we, of a resource to give you the sense of, what you can find. This is just a superb, example of a group working on sexually transmitted diseases that the Canadian Public Health Association worked on as well, that just gives some excellent idea about how you can enact the principles and monitor and evaluate the progress of putting those principles in practice in that particular context.
This one talks about the utility of a sex, gender, and equity lens, trying to blend those 3 things together to really consider all bodies and all genders. And in doing so, to sort of promote equity or the reduction of gendered inequity as a goal. And, it's one of the unique things about substance use is that the sex-related factors matter a lot as well to the body's response to ingesting a substance. And that needs to be taken into account along with all the gender-related and equity-related factors in terms of what impact it has on people's lives. So this one is a lot more complicated, and there are various ways into it around sex or gender-related factors. We see some examples here. Looking at, for example, in the 3rd one, integrating sex and gender informed evidence into your practice. This is a direct call toward one of the first principles we mentioned, and that is the use of evidence in making the public health response. And that was that's a handbook reflecting on how you do that in a service or a system design sense. Similarly, New Terrain does a similar thing. And the other one, well, the second one is just an illustration of a piece of knowledge product from Cannabis Hub, looking at a very specific question about sexual orientation, gender identity, and cannabis use. And again, trying to promote the evidence on that as one piece of the input into making a response to substance use.
And the 2 on either end are kind of neat. The New Terrain one is about trying to integrate both trauma and violence informed and sex, gender, and equity informed approaches together, fusing them together in a response to substance use. And the one on the left is about Indigenous community-based responses serving women who are pregnant and using substances, and thinking about culture-led and community-led approaches to how to enact that. So bringing sex, gender equity, and Indigenous led perspectives together. So lots to find in this workbook. You know, the links go so many different ways for you to find.
Yeah, that's what I was just going to reinforce, Nancy. Each of the lenses offers a really rich sort of set of choices, if you will, about how you can respond, and what kinds of products you can create, what kinds of services you can tailor, and how you can enter into this world of a public health response to substance use in so many different ways. So
yes.
here, you know, as you heard from the survey results and from the entire Normalizing Conversations project, there is growing support of this approach. But it's a very high level comprehensive thing. And that's why we worked with CPHA to do this particular workbook, to try and bring it down to some concreteness, to really explain briefly and straightforwardly what some of the principles are, what some of the lenses are, what some of the examples are of how you might adopt those things and integrate them into your own work.
And, you know, it is a work in progress, evergreen, I think. You know,
yeah.
As we continue to bring in the survey findings and all the different ways of knowing, whether it's from people with lived experiences, whether it's from the research evidence, whether it's clinical wisdom, whether it's policy wisdom. I feel like, you know, this is all of us trying to be in discussion together to think through how we do this so important thing of bringing what we know about public health approaches into really help guide the substance use field. So love to talk more, but we'll turn it back to you, Kelsey.
Thanks.
Thank you so much, Nancy and Lorraine, for your presentation. So we will also post the link to the handbook in the chat as well. And so now I'll invite all of our presenters to join back in with their videos, and we'll start the Q&A portion of our sessions. We have about half an hour left for that discussion. So I see there's a couple of questions that have been posted in the Q&A, and I think we have some questions in the chat. So I will stop sharing here just so that you can see all of our presenters here together. So
my video is acting up a bit, I see.
Oh,
anyway,
no worries.
Sorry about that. I don't know what the challenge is there, but I'm here.
That's okay. We can hear you clearly, so it's all good.
Kelsey, one of the first questions up here from Cassie has been up here for a while.
Yeah, let's start with that one here.
Yeah, it's kind of interesting because it asks really about that last lens we were just discussing. I'm a peer support worker in an ED in the Fraser Valley. I'm noticing our harm reduction program struggles to incorporate gender diversity, such as women not accessing our program out of fear of ministry involvement. How can we as a whole and as a team make our harm reduction more equitable? It's a fabulous question because it sort of raises a lot of the issues in the SGBA plus equity lens. And it is something that, you know, has been certainly researched and known about on the ground for years and years and years, that lots of women, especially if they are pregnant or mothers or have children at all, are very reluctant to go to treatment or any kind of service because of fear of relinquishing children or being forced to or losing custody of children. And, you know, that's such a serious problem that it renders treatment really gender inequitable. So I know Nancy's done a lot of work on this in the context of prevention of FASD even, let alone wider substance use issues.
Yeah. And, you know, we've done a lot of thinking about it, and there's a lot of answers to that question in this booklet that we made called Mothering and Opioids, with a lot of great people from across BC. But it does have a picture in it of, you know, how the substance use field and the child protection field can find a place of joint work. Each has their own work to do in terms of supporting women and supporting children. But there's a lot of collaboration that can happen within that. And they can be working from those principles that we've been talking about today, and shared principles around that. And that's why I think this workbook is helpful in some ways, because it keeps us thinking about these principles, and that allows us then to change practice to be sure we are addressing gender equity within the work that we do, and finding ways. And there's lots of questions in here about, and examples where child welfare and the addictions field have worked together to create responses that help mothers feel safe while still leaving the mandate of safety of children in place as well. So really a great question. I have spent like 30 years thinking about this one and working with organizations all across Canada and internationally. And I'd love to talk more to you, Cassie, about how we do this, but I know I'm taking up a lot of space. But to me, it's a really critical piece of how we change practice now, to think about the oppression of mothers and what happens when they try and get the support they so richly deserve from all levels of the substance use field. So thanks for raising.
Yeah, Kelsey, I might just add to that answer. It's not just an issue for women who are mothers or who are pregnant. There are lots of experiences of women who don't feel safe in harm reduction settings, or they don't feel safe even in certain treatment settings if they're not gender specific or sex specific and have information directed at them specifically. So I think there's a lot to think about in that realm for all genders and all bodies, to try and figure out what is needed in the tailoring department at all levels of response.
Absolutely. Thank you so much, Nancy and Lorraine, and for that initial question to get our discussion started. Another question we have posted here, and Tara Marie, this may be one that you can answer from a survey perspective, and Danielle, if you'd like to join in at all for more of that community lens. Did you find anything on social and health impacts of substance use communities? Examples given are secondhand smoking and smell allergies from cannabis consumption, or vicarious trauma from the use of drugs in precarious housing or poverty conditions. So Tara Marie, if you have anything to answer for that one.
Sure. From the survey perspective, particularly where we asked folks questions related to the perceived health and social impacts of substance use. And as I showed you, we wanted to keep things balanced by asking about beneficial aspects or benefits that people experience. And we also asked about perceived harms. I don't think it was among the ones I actually read out or thought of in the moment, but housing was definitely a key thread that came up a lot in people's responses in terms of the linkages between, folks who are underhoused, precariously housed, and the linkages that we know, and it's very backed up by a wealth of public health and other kinds of evidence too, and sociological evidence to show that there are those strong linkages between difficulty with accessing supports and services for substance use and difficulty accessing stable housing, for one. So we did hear about those kinds of broader social structural elements that impact substance use. This came through in a number of different questions as well. Like when we asked folks the question about reasons why folks may use substances, there was a lot in those answers around different social structural conditions as contributors to substance use. I think what's nice again about asking open-ended questions is that you are not just working with the fixed choices, you're allowing people to identify those patterns and where different elements overlap, right, in terms of key contributors to substance use, as well as different kinds of perceived harms and different kinds of perceived benefits. For some of the other ones that I noted in that question, we didn't hear as much about those. So the impacts of secondhand smoke and other kinds of what's often deferred or referred to as like nuisance, in relation to substance use. We heard less, I would say, about those kinds of impacts compared to some of the other ones I listed off that are really focused more on direct impacts on people's health, immediate health, well-being, mental health, and their experiences with stigma. So hopefully that helps address that question. I'd love to hear what others think.
Thanks so much, Tamara. Yeah, if anybody else wants to add on to that, please feel free. Totally okay. If not, we do have a couple other questions in the Q&A we can move to.
It's just really nice to see attention to nicotine and cannabis and smoking harms put in this. And so often nicotine's left out. So often the sort of harms of secondhand smoke are not, thought about. I think it's a really important issue about how we balance the, the safety of everyone. And
absolutely,
they're not easy questions.
For sure, yes. Lots of complexity. And I think, Tamara, you touched on that sort of at the beginning of your presentation as well, what people typically think of when they hear the word substance use. And when we think of this kind of more broad approach and trying to apply it to all substances, it's a very important point. We'll move to one of the questions from an attendee. So how do we support Indigenous populations and substance use who are disproportionately represented in using substances, but have exceptions on reserve that increase access to substances that can increase their risk? And any comment as far as policy work that can be done? Of course, that's quite a broad question, but if anybody wants to jump in on that one.
I guess my experience in working with a number of Indigenous communities across Canada is that the work needs to be community-led, right? And even though the policy is federal, it feels to me like the action to make it a public health approach happen needs to be generated in that community based on, culture, land, lineage, language, really important. And that's what that one little booklet that we showed you did, was just some great examples where communities have taken up that challenge and to prevent alcohol use in pregnancy, but you don't actually see the word FASD on the door or the name of the group. It's much more about finding a cultural identity that gives strengths in different ways to people's health, rather than coming in from the problem or deficit lens, coming in from the wellness and wisdom lens.
Absolutely. Thank you, Nancy. Did anybody want to add on to that? We do have another question that's kind of specific to that community-led approach that we can get into next as well.
I can weigh in a little bit. And so in terms of like policy, federal level, and thinking in terms of like legislation, like I think something that comes back to is how do we embed this public health approach within our legislation, within our government and our understanding? And so also thinking about how there's the overrepresentation of, as brought up, of substance use within the Indigenous populations, but then also the overrepresentation of Indigenous folks that are in our prisons and jails, and so whether it's directly related to substance use, like the crime that they are convicted of, or whether they're convicted of something else. We know within, at least within our federal prisons, that at least 80% of those individuals have a history of substance use. And I don't think that's a coincidence, especially also knowing that people that get involved with our justice system generally have poor outcomes in relation to the social determinants of health and all that sort of thing. So I think there are need for like community-led initiatives, but I think one of the challenges with implementing this this approach is figuring out how do we embed, how do we look at decriminalization and legalization and evidence-based approaches that will actually meaningfully address the reasons why people come in conflict with the criminal justice system or why they're experiencing harm, why they're using substances in the case where they are using it in a way that is detrimental to their health or to those around them, as sort of the previous question was mentioning, and sort of looking at it from that perspective. And so I think we're needing to start increasing our advocacy to those in the Senate, those in our members of parliament and like the leadership and those decision makers, and bringing them into this journey where some of those individuals sort of already are, but kind of trying to bring everyone along and figure out how we can work on this together, advocate for the government to invest in initiatives and invest in the community who already have many of which have the knowledge and expertise to be supporting their own community members or other people that they come in contact with and who have those services, but are frankly lacking the resources. So just in terms of with the federal system, the Correctional Service of Canada, for 40% of the individuals that are under their care and custody are in the community, but only 6% of their budget goes towards community supervision. And so looking at the allocation of resources, and I think also encouraging the government to appropriately relinquish control in certain situations, which I don't think sometimes just the general public, but the government can be very uncomfortable with that. But recognizing the expertise that it already exists and investing in those resources. And so I think that's kind of my thought on how we kind of like move forward, and making sure there's appropriate representation with the decision making along the way as well.
Thank you so much.
I think those are really great comments, Danielle. And I think just sort of highlights the challenge of the public health approach, because it has to involve policymakers at the end of the day. And it also has to involve perspectives that link policies together. So at the moment, that's not often done by governments, either by levels of government or departments. But all of these things matter when we look at the principles and lenses, even just in the workbook. We're pulling together housing policy, justice policy, health policy, et cetera, child welfare policy, you name it. And unless those things are working in concert deliberately, I don't think we're really going to get there. So thanks, Danielle. I thought those are great comments.
Yeah, thank you both so much. Tara Marie, I don't know if you wanted to add anything in kind of connecting that implementation piece back to some of the barriers perhaps that we heard about in the survey findings as well.
Well, just as I was listening to these great comments from Danielle and Lorraine, it had me thinking about the shift and evolution in our own thinking in this work, which really represents, taking what we heard from the survey and, thinking about the themes that we're writing up now for some of the other knowledge products like the paper, where we are talking more about community-led approaches. I totally agree. And I think it's an important shift in our thinking that's happening over time to looking more at strengths and resiliency versus, limitations and harms. And I think that that's wonderful that that's come out in this discussion. And, to link that back to what we heard in the survey, and this is much more documented in the report. So it's another great place in which people can can hear more of some of those perspectives, where a number of participants in unpacking their view of a public health approach to substance use positioned it against what it shouldn't be. And so we heard many participants answer questions around a public health approach to substance use by stating very clearly that current policies, programs, and many practices and approaches to substance use have been based on colonizing structures, as well as systems built upon systemic racism. And adding that these structures have not only failed to effectively address substance use or problems associated with substance use, but they have indeed disproportionately had impacts, many negative impacts on Indigenous and racialized communities in particular. And noting from there, however, that these and other communities are really leading the way in new approaches, and particularly in developing more holistic, culturally safe, and sensitive approaches that are more meaningful, more tailored, and perhaps will have better engagement for folks. So that's something we take up in the survey report with a number of really illustrative and powerful quotes. And as we've moved through in our own thinking, as I mentioned before, in doing this work and writing up those themes, we realized, no, there's something here there's a story here to tell about next phases, and really paying careful attention to community-driven and community-led approaches. How do you pack all of that into a definition of a particular kind of approach can be a challenge, but it's important that we are hearing these voices and paying attention to those complexities and the resiliency.
Absolutely. Thank you so much for adding that, Tara Marie. Just noting the time, we have about 10 minutes left, so we'll get through a couple more questions. Apologies if we're not able to get to all of them. One question that we have posted in the Q&A here, I'd like to hear more from the panel about the reference to greater inclusion of community-led perspectives in the context of suggested changes to the public health approach definition. And they've noted, I'm increasingly engaging with community associations surrounding supervised consumption sites who are concerned about the social disorder surrounding those sites and the community trauma that results. Community groups are concerned that their interests are not reflected when developing and implementing harm reduction approaches to substance use. I'm not sure if, Tara Marie, if you would like to start with that one from the context of that suggested change, but if anyone else would like to jump in, please go ahead.
It was one of the themes that we talked about, right, under unpacking what a public health approach to substance use means. What are some suggestions for that definition? Indeed, the top theme, if we went back to the slides, was around greater inclusion of people with lived and living experience. And we heard this in relation to a number of suggestions, in particular, recognizing very explicitly that people who use substances are the experts as well when it comes to understanding substance use, when it comes to understanding the various things we asked about in the survey, actual harms and benefits, and preferred choices when it comes to any potential interventions and approaches, and most importantly, key principles and goals. And another idea that was very much connected in those responses, and we take this up in the paper that's evolving too, is where a lot of folks said that people with lived and living experience, because of lived experience of stigma in relation to substance use, are also such key experts to bring in any stigma reduction related efforts in terms of helping others understand the effects of stigma, in terms of choosing and helping to choose non-stigmatizing language for any resources and education as we move forward, including all of our endeavors around developing materials and resources around a public health approach to substance use. So having that involvement, being explicit about that expertise, and in particular, linking it to efforts around stigma reduction are some of the things that really pop out for me in reaction to that question.
Thank you, Tara Marie. Yeah, if anyone else wants to add on, I'll connect it as well to another question posted in the chat, just asking about where substance use harm reduction falls into this approach. Danielle, I see you're unmuted if you want to elaborate on either of those.
Yeah, so in terms of I think the actual implementation too is thinking about how are decisions being made in what rooms and who's involved in that. And so I think part of, and what Tara Marie was saying about the colonial structures that we're operating within and deconstructing those, is that at the moment unless there is some really large sort of political public will that politicians are sometimes bending to, that oftentimes it's these certain set of people which are there's growing diversity within like these decision-making rooms, but I think it's still not where it needs to be. But looking at sort of removing those hierarchies and those silos where decisions are made, where policies are made, and or definitions are made even. And so looking at, it's like, okay, is it just people in government? Okay, but where are the, you know, professionals who are providing services to those who use substances, which may also be people who use substances, but those people that are accessing those services or have those needs, and also thinking a bit broadly about in terms of like who's actually involved, who's impacted. And so I think linking back to one of those first questions about thinking about sort of the maybe secondhand harms in relation to substance use, but bringing those folks in, and figuring out how to meaningfully engage, because at the moment I think there's a tendency for government to frequently say, okay, we've consulted government, we've asked we've consulted the community, we've asked for their opinion, check, and then they can move on. And so there are certain ways in which our organization that we kind of question the efficacy and like the time spent that we consider into these opportunities to consult, because we don't know what's being done with our feedback. We don't know how those decisions are being made. And then oftentimes also these decisions and policies are being made in silos. And so I think that's one of a real strength of this public health approach, is trying to break that down, recognizing the substance use being on a spectrum, but then all of the contributing factors, and then all of like the varying paths that people go on. And then so, because oftentimes we'll think about, okay, so there's women, then there's Indigenous, then there's this population, there's justice involved people, but we could be having all of these different conversations in different rooms, and you could be talking about one person who applies to all of those categories or many. So it's involving the intersectionalities. And so I think that's sort of an important point about involving the community, is thinking about who those community members are, and then finding meaningful opportunities for engagement and inclusion, because I think that meaningful part is sometimes what's missing.
Yeah, thank you so much for sharing those insights, Daniel. We really appreciate it. And I think you've spoken to that intersectional and kind of the different silos that come together in a public health approach, and how complex it can be. But yeah, thank you so much. So in the interest of time, we'll just move on kind of to a final question for each of our panelists today. If each of you could just kind of provide a key message or a finding that you hope that our audience today can take away from this discussion, it would be great to hear from each of you if anybody wants to start, and that'll kind of wrap up our discussion.
I don't know. I'll start if you like.
Yeah, thanks, Nancy.
I think for me, and being involved in the workbook and in today and in the work I do overall with women and girls and substance use particularly, but also gender equity overall, I think for me, it's what's so important is, as Daniel was mentioning just now, is that we have opportunities to talk to each other about these things, about how we see bringing these lenses in and linking them up in a really useful way based on, you know, the context and the evidence. I really feel like we need lots of opportunities to be able to discuss them together, and not only are they siloed in terms of making policy, I feel like we're siloed in terms of being able to have these discussions that we're often, you know, over in a corner. So my key message is thank you, CPHA, for, you know, putting forth the idea of this public health approach and inviting us to begin some collective discussion on it.
Thank you so much, Nancy. Lorraine, if you want to add on to
Sure.
that.
Quite different comment, and something we haven't talked a lot about, but I think just expanding the notion of what evidence is and including so many different forms of evidence is a really interesting and important aspect of moving forward on the public health approach. So, you know, that does two things. It reinforces the importance of having evidence, but it widens the kinds of evidence we can bring to bear on a practice or a policy or something going forward. And I think the discussion today has really illustrated all the different places from which we can draw evidence going forward and how that can only help support the public health approach.
Absolutely. Thank you so much, Lauren. Danielle, if you'd like to go next, if you have any final thoughts.
Yes, I'd echo what Lorraine and Nancy have said already, and I think I can preemptively echo what Tara Marie is about to say. But I think it's difficult to figure out just what one sort of takeaway from this, because there's so much good information in this and so much that's important. But I think something that, especially considering the organization that I work for and the people that I represent, is just coming back to criminalization is not solving any of our problems, whether it's substance use related or otherwise. This practice it's harmful, it's counterproductive, and it's costly. And we have so much evidence to show that keeping people connected to their communities, providing support, especially peer-based support, and meeting people where they're at is so necessary. And that continuing to stigmatize people, not only by now calling them like what is an addict or drug user or whatever stigma that title is, but then adding on a criminal record on top of that, there's already enough barriers to actively participating in community. And so I think it's just reinforcing that we should be thinking more about how we are addressing the root causes of harmful substance use, and just making sure that everyone has equal opportunity for meaningful lives and participation.
Thank you so much, Danielle. Tara Marie, I can pass it over to you. We just have a minute or so left, but if you have any last thoughts.
Sure. And just to jump off those great comments again, thinking about how do we address the barriers to implementing more compassionate, evidence-informed, community-driven approaches. If that is the ultimate goal with stigma reduction around substance use, then we really do need to talk about some of the other broader barriers. And I realized all too late that I skipped over a slide that actually, gave some of the data we have. So I invite folks to go back to the report where you see a breakdown of common barriers to implementation. And unsurprisingly, while funding and resources are top, also receiving a lot of support were a lack of knowledge, or where there are gaps in knowledge and gaps in training. And those are the very kinds of gaps that we can and are filling with this kind of work, with generating this kind of knowledge and new resources, especially when we listen and develop those resources in concert with communities most affected by and involved with substance use and substance use related interventions. There's so much potential here. And so I think that for me, although there's many takeaways, that's something I wanted to leave the group with.
Wonderful. Thank you so much, Tara Marie, and to all of our panelists. So we really encourage you to look at all of those resources, the survey report, the handbook, as well as those research snapshots for everything that we discussed today. But we want to thank all of our panelists for joining us, thanking all of our attendees, the great questions that were provided. We know this is just the tip of the iceberg on a much larger conversation. But thank you all so much. And again, we really encourage you to complete the post-webinar survey, provide us your thoughts and insights, as well as signing up for the SURE newsletter and attending our upcoming webinars, our next one being on November 7th. So thank you again, everyone, and hope you have a great rest of your day.